Very good morning, Dr. Mark Vanderpump. Thank you so much for joining us this morning here at Top Doctors to talk about thyroid, our latest topic of discussion on our YouTube channel, also on our podcast. And Dr. Vanderpump, before we start our discussion this morning, thank you so much for joining us here at Top Doctors. A very welcome to you.
Thank you very much. Good morning.
So Dr. Vanderpump, of course, a very highly regarded London-based consultant endocrinologist. So he's here to talk to us about thyroid and thyroid disorders. And before we get into the topic, Dr. Vanderpump, if you wouldn't mind providing us a little bit of background information about your experience and areas of expertise.
Yeah, so I'm I suppose, a fairly senior consultant now. I've been around as a consultant for over 20 years. My NHS career, I worked at the Royal Free Hospital for 16 years, but for the last few years, I've been working just solely in private practice based in London. And as an endocrinologist, we see a whole range of hormone disorders, from diabetes to thyroid to pituitary to ovary, testes. So it's all across a broad range of all the various endocrine disorders. I work at various clinics based in central London, both in the One Welbeck Endocrinology and the Physicians Clinic in town, and also in a local clinic in Golders Green, Wellington Diagnostics. So, life's busy at the moment, so it's good.
Absolutely, doctor. That's a very good to hear that, life is busy, and it sounds like you're very passionate about what you do. And I think a lot of people watching and listening this morning will be interested to find out about thyroid disorders. And what is the role of one's thyroid exactly, and how important is it?
Yeah, well, going back a bit, because within our specialty, we choose part of a specialty to specialize in. So when I was a young doctor, I got involved in a research project looking at how common thyroid disorders were in the community. And thyroid disorders are, in fact, quite common, particularly as we get older, particularly in women rather than men. And I always thought it was a relatively straightforward gland. It either got up, got smaller, got bigger, got made more hormone, made too little hormone. It seemed fairly straightforward as a gland. I didn't realize it would become so complex as I got older. But in essence, the thyroid gland is important. It makes two main hormones, but they're involved in cell metabolism. So it's basically how our engine ticks over, and almost all cells require thyroid hormone and nearly all body processes. But particularly growth and development, it's got a key role in pregnancy as well. So it's a bit like your engine ticking over. So when you don't have enough of it, everything becomes slow and sludged. And when you make too much, everything rattles away and you feel like you've got a runaway sort of steam train type feeling. So we're trying to keep our hormones in balance, and the thyroid hormone is very key in terms of nearly all those body processes.
Fantastic, Dr. Vanderpump. I think people haven't realized how important the thyroid actually is and how much it can affect our health. In what ways can it really affect us positively and negatively?
Well, yeah, I suppose it's one of those, because it's just a small butterfly shaped gland. It just sits below your voice box. And I suppose you don't realize you don't miss it. You don't realize it's there until you start missing it, or it starts to misbehave, I suppose. And so, as I said, the three main things that happen is, one is it can just become enlarged and you can grow nodules, which is similar to any other endocrine gland, and therefore there's concern whether it might be a tumor or something like that. Then secondly, it can fail and it can just not make enough hormone, which is called hypothyroidism, or it can start making too much hormone, which is called hyperthyroidism or thyrotoxicosis. So in a sense, the symptoms and the disease associated with thyroid represent either the thing getting larger or making too little or making too much. And there's a whole group of symptoms associated with too little hormone and a group of symptoms associated with too much hormone. So thyroid failure, which is probably the commonest, is actually quite common, particularly in older women. It's in this country, in the UK, it's typically due to autoimmune disease, which is sometimes called Hashimoto's. And that's when your body makes an antibody, and it should be recognizing a bug or a virus, but actually recognizes your thyroid cell as the problem instead. And so the thyroid gland gets attacked by your own immune system. And that's what Hashimoto originally described over 100 years ago when he was operating and noticed that women had an enlarged thyroid, and implied there was some other process other than iodine deficiency causing, which was the commonest cause at the time of goiter. And so when they recognized the antibody 50 years later, they named it after him in recognition, as he was the first person who described the typical appearances when he'd on histology once he'd removed the thyroid gland. So sometimes the thyroid gland can get enlarged, but more commonly it becomes atrophic in that process. It just means it's wasting away. And so therefore, what you then have is a long, and it can be over many, many years, a slow decline in thyroid function. And so it's not unusual now, particularly in these days where people are having a lot more blood tests, is that they get picked up long before sometimes they notice the symptoms. So we have a concept called subclinical or mild, which means that the blood test is showing a problem long before the patient notices. So it's a bit like if you've got a temperature in the room that you have and you like to have, if you walk in the room and it's dropped by 10 degrees, you notice straight away. But if that temperature drops over many, many years, you could walk in at the end of the room and actually still think you're at the same temperature until the penny drops. So it can be a very slow decline. And so sometimes it's only in retrospect the patients notice that actually they felt more tired, they might have gained weight, their skin might be dry, they might feel a bit sort of intellectually obtunded or subdued, they might have sort of scalp hair loss. Women can have menstrual disorders, men can lose libido, constipation, a general feeling that everything's become a much more sluggish and sludged up. So therefore, there's a clear diagnostic test that tells us whether your thyroid gland is working or not. And what we have in our brain is a gland called the pituitary gland, which is sort of a main command center for our hormones. And what that does on a daily basis is monitor how much thyroid hormone we're making, and sends a regulatory signal back to the thyroid telling it it's working okay. That signal is called the TSH. And some people may be reminded that on day 5 of life, children have, or babies have, a heel prick test, and that's by the midwife, and that's screening for the 1 in 3,500 children who are born without a thyroid. It just doesn't develop in the womb. And so within 5 days of being born, the pituitary gland is telling the body that it's not got a thyroid gland. So that TSH measurement on day 5 is a way that we have of screening for congenital hypothyroidism. And so early on, the pituitary gland starts to get a sense that things aren't working. So this signal rises. It's called a negative feedback. It's a key principle in endocrinology. The TSH rises in response to the lack of hormone, in a way of trying to shout or try and get the thyroid to up its game and start making hormone. And people have a threshold where they then start to notice that reduced function. And so we can measure the antibodies, we can find out what the cause is. And so that would be the commonest cause of what we call spontaneous hypothyroidism. In the community, about 1/3 of patients on thyroid are on thyroid hormone replacement, or they got thyroid failure because the doctor has done something to them, which is normally an operation or radioiodine. And so there are a large group of people who have surgery or radioiodine to have a failed thyroid gland. There's the group who are spontaneous. There's the group who are born without a thyroid, and there are 1 or 2 other rarer causes, particularly associated with some drugs, including some of the new immunotherapies are being used for cancer these days. So quite a wide range of causes. And so once you've made the diagnosis, we have a replacement strategy of giving you that hormone back. And we're fairly fortunate compared to other endocrine glands in that the tablet we give you back is the same as you are making. So it's actually fairly rare to have side effects, because it's a synthetic version, but it's identical chemically to what you are not making enough of. And so we can replace that and allow the pituitary to think it's done its job, because the signal comes back down as you give the hormone back, because the pituitary doesn't realize it's coming via the stomach rather than from the thyroid gland. So it can it gets a sense that actually the hormone is being restored. And I would say that that does a good job for the vast majority. There's a few, there's a minority who don't get quite back to their former selves despite that adequate test. And so they have a different combination therapy, which can give them T3. I mentioned T3 earlier. T4 and T3 are the 2 hormones. T4, which is the tablet, is what we call a prohormone. So that has to be converted into the active hormone within the cells. So for most part, that happens, but some people need T3 and T4 combined to replace. But at the end of the day, what you're trying to do is return that person back to normal physiology, and then you hope that the symptoms get reversed that they had at the time of the diagnosis. So when you're looking at thyroid overactivity, again, there is an autoimmune cause is the commonest cause. So in that situation, the antibody goes in and it turns up the dial. So instead of you walking into a room of 70 degrees, you walk into the room and it's 90 or 100 degrees. And so that antibody recognizes the thyroid cell again as the foreign agent, but instead of destroying the cell, it turns up the production. And so the thyroid gland makes thyroid hormone from iodine. And so if you have enough raw material, you can make as much hormone as that signal tells you to do. And so Graves' disease is the name given to the thyroid overactivity due to the immune system. Other causes include nodules. So we mentioned nodules earlier. Sometimes they can become what we call autonomous and become independent states and start making extra hormone outside physiological control. There are some short-term and temporary causes where you have what's called a thyroiditis, where either the immune system or a virus temporarily upset the thyroid. You can release a lot of stored hormone into the circulation, and then that tends to wane within 2 or 3 months. So the thyroid overactivity can be permanent and it can be short-term. And again, we rely on our thermostat, our TSH, to tell us when we're making too much, because the TSH gets switched off in recognition that you are overproducing. And so it's almost like the brain trying to turn down the thermostat, but it can't do so because the thyroid has sort of lost control. And so the symptoms of too much hormone tend to be weight loss, palpitations, feeling agitated, nervous, sometimes diarrhea, increased bowel frequency. Women's periods can stop again, men can drop libido. So a wide range of symptoms, again, associated with too much hormone, almost the opposite of the ones that they had with too little. The treatment options for overactivity are a bit more complex. Firstly, the short-term temporary form tends to resolve spontaneously. So in those cases, a question of just watching what we call the natural history with an expectation that usually things come back to normal. If it is permanent and it's confirmed to be permanent, there are 3 strategies. I mentioned radioiodine and surgery earlier, so they would induce underactivity because they tend to get rid of the thyroid gland. So you can have your thyroid removed, or you can have radioiodine, which is a clever trick where if you attach radioactivity to iodine, it just goes into the thyroid and kills the overactive part of the thyroid, either the whole gland or certain nodules. But both of those options do tend to run the risk that you're going to be underactive afterwards and need long-term thyroid hormone replacement. People with Graves' disease, particularly in the UK, tend to get given a course of what we call anti-thyroid drug therapy. And that just blocks the iodine getting into the factory. So you can dampen down the production, put the thing to bed for a while, hope the immune system winds down and disappears. And then when you stop the tablet, the problem has gone away. Unfortunately, that probably works in only about 50% of people. So then the other 50% get it back. And then you have that long-term management problem. So you can either go back on the tablets or think about the radioiodine or the surgery options as a long-term. And it depends where people are in their life, whether they want children. There are 1 or 2 issues around pregnancy. So we don't tend to recommend women are on tablets for overactivity if they're thinking about a pregnancy or they are pregnant. So there are issues with different people at different times in their life in terms of what would be the best treatment option for them.
Fantastic, Dr. Vanderpump, and absolutely a really interesting and comprehensive overview there of thyroid disorders. And I suppose a question just popped to mind about the age, or what is the most common age that people would maybe notice a change in their thyroid, or when would you recommend people to get their thyroid checked out? How often?
Yeah, so I mentioned the screening program on day 5 of life, which is for all babies born in the UK. And it's a relatively rare disease in children. Most autoimmune diseases tend to be later in life. And there's this interesting association with women and various sort of hormonal changes. So, for example, pregnancy or the menopause. So the autoimmune diseases in general tend to be more common in women. So the peak age for both hypo and hypothyroidism is in that sort of 4th to 5th decade. And but it does occur in men as well. It's just 10 times as common. So there are various points in your life where you might have a screening program, but we don't have an active screening program. You tend to need symptoms or signs or some reason. But in general, if you were going to do a screening program for the population, if you went to women at about 50 years of age, you'd probably find about 1 in 10 of them have subtle signs of thyroid dysfunction. So although they may not all have symptoms, you might put them in a risk group for the risk of developing it later in life and institute a longer term surveillance program. So that has been looked at as a concept, but I come back to the fact that a lot of people are found, when you do screening, are found in this subclinical zone, i.e. there's a subtle deficiency or a subtle excess, but they don't notice it yet. And so there's a bit of debate about what point within the natural history it's worth knowing about that, because screening and being told you've got something doesn't always help you. So for example, if you tell someone their blood pressure is high, they start having days off sick that they wouldn't have had before because suddenly they feel unwell. So there is quite a lot of ethics about screening. And when you tell someone they have a problem, and then, because you may not do something about it, you might just say, well, okay, we're just going to watch this now and see. And then there's a difference between people who say go for a well-woman medical and get found versus those who have a symptom. So I think if you've got a symptom and you have an abnormality, you tend to then encourage treatment. Whereas if you're found and you're completely well, people tend to want to leave it. So it does depend on how you've actually accessed the test and how it's come to mind and what the patient feels about it. And I mean, a lot of the time now we're sort of just saying to someone, look, you have the problem, you can have a trial of therapy. So there is a more pragmatic approach where you say, look, within 2 or 3 months, you will feel better or you won't. And so you therefore could offer someone a trial of treatment. That's one option. I think certainly the younger people, with either too much or too little, if you are in these sort of marginal zones, there are some long-term health disadvantages. So particularly with hypothyroidism, there's an association with an increased risk of cardiovascular disease from some population studies. So I suspect in more subtle dysfunction, you might treat in a younger person than an older person. And then with overactivity, there's a risk of something called atrial fibrillation, which is when your heart gets triggered into an abnormal fast heart rhythm. So there are some long-term, particularly cardiac disadvantages from subtle dysfunction. But clearly, if someone's got symptoms and they've got a clearly abnormal test, they're all going to get treated. But I think there is a bit of debate about the more marginal tests and what you do. So the problem with a screening program is that you can often say, okay, I'm lethargic, I'll have a check of my thyroid function. The big debate then becomes whether the thyroid function is actually responsible for your lethargy. Because if you correct the blood test and you're still tired, what do you do then? Is it still the thyroid, or do you have to look elsewhere? So part of our job really is just to make sure that people aren't just going down the one line, it must be my thyroid. And as a physician, we're sort of keeping an open mind as to whether there's anything else going on that might be causing the symptoms, because at the subtle end, it can be difficult to always explain everything from just the thyroid dysfunction.
Absolutely. Dr. Mark Vanderpump, fantastic again. A really comprehensive overview there. Fascinating insight. And I think anybody watching or listening who might be worried about their thyroid function, or like you say, if they're feeling lethargic or very, very tired, a little bit high blood pressure, I think it's very important that they probably get checked out quickly. Would you recommend or give that advice?
Yes. I mean, I know there is some controversy about this, but we can actually rely on our pituitary gland to tell us if there's a problem. And so for the vast majority of people, if you've got a normal functioning pituitary and it's responding appropriately to your thyroid status, if the pituitary regulator is happy with the amount of hormone you're making, you can usually assume that you've excluded thyroid disease from the equation. So that sometimes therefore becomes quite a useful marker, because as I said, with the pregnancy, within 5 days of being born, that marker is screaming at your thyroid saying, where is my hormone gone? So what I'm saying is that you can use that. It's a very sensitive mechanism. So long before the patient gets unwell, the pituitary gland is noticing the problem and is trying to tell the body that there is an issue here. So we can use that lead-in time and also reflect on making the pituitary happy again as our way of acknowledging that you're adequately treated, whether you've been under or overactive. You can use that marker. Now there is some debate about whether that works for everybody, but I think for the vast majority of people, I think those rules tend to apply, and that's true for. And I think it's much easier for thyroid patients patients in a way, because we've got tablet options most of the time for HRT or testosterone or adrenal hormones. Their regulation is a bit more tricky, and so therefore the blood tests can be a bit more difficult. But I think at least in thyroid, we have a clear idea at least that you've been adequately treated or not, with a relatively simple regime. I mean, if we compare, so we talked about the autoimmune process earlier. So in people with type 1 diabetes, and just to make it clear that if you have thyroid disease, you are more at risk of other autoimmune diseases. So they are what we call organ specific. So with the pancreas, that's when your immune system targets is the insulin producing cells, which is why you need insulin for life when you've been diagnosed. You can have vitiligo, where the immune system targets the skin pigment cells, so you get a white patch. You can have alopecia, where it targets the hairs in the scalp, so you have a sort of coin-shaped bald patch. There are other rare celiac disease where you're gluten intolerant. So there's a whole family of diseases. Thyroid is by far the commonest. So if I go into a thyroid clinic, most of the other diseases I would see are very rare. But if I go to, for example, a vitiligo clinic, I'd probably expect about a quarter of them to have thyroid disease. So it's always that way round. And if I go to a diabetic clinic with type 1 diabetes, those people with type 1 diabetes, about a quarter, particularly women, might be a quarter of them might have thyroid disease. So it's always that way around, but it is within this family. But you know, the patients who have diabetes, you have to replace insulin. That's not quite as straightforward as taking a tablet, for example, because obviously you need injections and things. So we are relatively fortunate that our replacement strategy is probably as simple as it could be compared to some of the other glands.
Absolutely. Dr. Vanderpump, fascinating again. And I want to say thank you so much for your time this morning, and a really, really helpful discussion, I think, for your patients listening. And for anybody who would like to find out more information about Dr. Vanderpump, you can head on over to his Top Doctors profile at www.topdoctors.co.uk. Once again, Dr. Vanderpump, many, many thank you.
Thank you very much indeed.